everybody, and welcome to another edition of Smarter Sourcing, the Healthcare Edition, a podcast where we talk about healthcare supply chain issues with leaders, the things that they're facing today, challenges that they're overcoming, sometimes through a prism of history, but mostly just kind of looking forward. So I'm your host, Eric O'Daffer, and appreciate everybody that's been able to be part of our audience as we're now on our third episode. So thank you all for the great feedback. And today is a terrific episode. We have got Teresa Dail here with us from Vanderbilt University Health System. And Teresa is the Chief Supply Chain Officer there. She also has a myriad of other titles that we will go through today in our podcast as we cover this. She's an entrepreneur. She's done lots of great things in the healthcare supply chain, a Bellwether League inductee in 2022. Welcome, Teresa.
Thanks, Eric. It's great to be with you. I'm excited to join you today.
Well, we're going to cover a lot of ground, and I think really first step, you've got a clinical background and a supply chain background. Today, do you consider yourself more of a clinician or a supply chain leader or both?
I don't think you will never not be a clinician. And part of me, I feel being successful as a supply chain leader is because I am a clinician. And so that part is always going to be with me.
So one of the things is you've been a healthcare supply chain leader for all of these years and just done so much across the industry. A person that knew you well described you as a savvy agent for change. How do you get somebody to identify you as a savvy agent for change? It sounds great. How does that come about? And do you agree?
It's not someone I ticked off, I guess. I'm forcing them to listen to some of my crazy ideas. I think as I was thinking about sitting down and talking with you, and you're right, I didn't even realize it, 25 years now. 2001 is when I started in supply chain. And I was just too naive back then because I didn't really know anything about it. I was hired because I was a nurse and because they wanted me to try and develop the relationship between, they called it materials management back then, and some places still do, right? And I think that's just very descriptive of how people viewed us, in that we just kind of moved stuff around, stocked the shelves, and that was really it. And I came into it with a completely different lens, not really even knowing what I was supposed to be doing. And so it was easy to try and evoke change and try different and new things because there was really nobody to tell me that I couldn't, right? And it was experiment with it, and if it worked, great, and if it didn't work, that was okay. And it seemed like your teams get excited about that stuff. They're just doing the same thing every single day, and people were just doing the same thing every single day. And even way back then, I started messing around with, org charts and roles and responsibilities of supply chain itself and how we were interacting with the clinical side of the organization and how we interfaced with other major departments within the hospitals. And it just reinforced the fact that we could continue to evolve, and that the organizations were willing to accept that. And more importantly, the team was willing to accept that.
Yeah. And a lot of, in those early days, if I'm not wrong, a lot of it was on the clinically focused supply chain. How did you provide a lot of leadership. How did you get that alignment, get that agreement at academic medical center back in the day? I know Vanderbilt's expanded a lot, but on that day, that's a tough sled.
When I was actually hired at Orlando Health, I had worked there for 17 years as an ICU nurse and a nursing leader, and was hired back to that organization to try and build the relationship between the supply chain team and the clinical teams, because there was such a void. It was a Grand Canyon of lack of interaction and collaboration. And it was really very evident to me that they were not wrong. They were making decisions in silos that were leading to downstream consequences for the clinical teams. and they were not getting any input. They were not having any engagement. And so it was easy for me there, because I had all those relationships, to start having those conversations and start bringing physicians and nursing into, and other departments into the conversation with the team that I was responsible for, which was all of contracting at that time, essentially, and was given a charge to try and think about, how do we do something formally. And I literally remember I wrote the first, if you want to call it, value analysis process for Orlando Health, flying on a plane, going to an AHRMM meeting. And I was thinking about, how do I do this with community-based physicians who are in competition with each other for their practices, and I want to get them to sit around a table and have a conversation about, what technology we should be using. And honestly, Eric, I think it was relationship driven that allowed us to take those first steps. I mean, that was in the early 2001, 2002, 2003 that we were doing that. So when I was recruited to Vanderbilt, I was very blessed because nobody knew me from Adam there, right? And I was blessed by having 3 surgeons, an orthopedic trauma surgeon, a liver transplant surgeon, and a pediatric spine surgeon, who all were very interested in this growing notion of physician engagement in supply chain decision making and cost per case analysis, and how did they start wrapping their arms around it and getting involved with it. And so the president of the hospital put me in touch with these physicians who were talking to him about that, and we developed the process that's at Vanderbilt, which has been in existence now since 2008. But it was that, I didn't have any credibility there, but I came to it with having done it someplace else, and also, again, a nurse who I could sit and talk with them and say, well, this is what worked. This was, what I encountered there. They were talking to their colleagues like at Stanford and other places who were trying to do the same thing. And we were able to pull it together. And 3 of those physicians that were original charter members of the committee are still medical directors to this day in that group that help lead some of those supply chain interactions with physicians and clinicians. So it's been a great journey. Yeah.
Yeah, that's an amazing thing. I talk all the time. It's a common theme, I guess, of these podcasts, is sustained effort. To have the same people in place 17 years later is a testament to what you did. And I love, as somebody who's productive on airplanes, to hear that the main genesis of this came from a flight that you were connected on. I'm always telling my wife and my kids, this is my time to focus. I don't know why I'm good here, but I'm good. So it's great to hear.
You're right.
And you've expanded so much. I mean, when we, in the introduction, we talked about all the titles that you have today. Can you walk through those titles and how, I don't know, sometimes it's, supply chain does a great job and they get things, given to them, I guess, voluntold to do them. But in your case, it's a little more entrepreneurial than that. How did these different things come about? What all titles does Teresa Dail have these days?
Well, first title is wife, mother, and grandmother. So we'll take that one first, right?
That's a great one.
Then comes the nurse in me, and then is, Chief Supply Chain Officer, which I was very blessed to go into that role just several years after joining Vanderbilt, and have been able to just build a phenomenal team on the inpatient, on the hospital side of the organization, because it really, not unlike other academic medical centers across the country in like 2007, 8, 10, and even some places, even today, supply chain was sort of not congruent in what it was doing and who it was reporting to, what its responsibilities were. And in our case, we were with the university, and half of what was done was on the university side and half was on the medical center side under 2 different leaders. And so they asked, when they recruited me, I said, well, I need a consolidated team. I mean, we've got to focus. We've got a lot to do. We had to rebuild all of supply chain, right? So while I was doing that, it was simmering in the back of my head that we can do other things. There's a lot of talent here. It's an organization that that really prides itself on innovation and really looking at ways to not only affect and patient care, which is really important, right? But also the well-being and the work environment of our providers and our clinicians and our other staff members as well too. And it got me thinking that we had started in Orlando a small self GPO down there before I had left. And so I had the experience in the background of having helped stand that up and then being the primary customer of it because it was wholly owned by Orlando Health, and had been working for about a year with the president of our largest hospital, and he was also over all our ambulatory clinics. And I had ran this idea past him, and I said, I know we can do that. We through our physician engagement model had gone to sole and dual source contracts in most of our physician preference items. And so we were hitting these price points and having high contract compliance with a variety of physician preference items like total joints or cardiac rhythm management, whatever it is. And I'm like, if we can do this ourselves as Vanderbilt, as an academic medical center, we can do this with other people, other customers as well too, other hospitals, and get them to come in and do even better from our price point perspective. And that started the genesis of the Vanderbilt Health Purchasing Collaborative, which I'm president of. And it really took hold when Vanderbilt started our health affiliate network, which was really looking at really lowering the overall insurance expense for the employees of these various health systems within the state of Tennessee. And the CEOs were asking, is there anything else that you can do to lower our overall expense? And our deputy CEO of the health system called me and said, Teresa, have you ever thought about doing something in supply chain around maybe lowering supply expenses for other hospitals? And I said, as a matter of fact, we've been working a year and I have a template of what that could look like. And I think we're ready to go. And he's like, great, let's do it. So we got in a car and started going around and talking to folks. And lo and behold, the collaborative was stood up, and I'm not going to do a commercial for it, but it is in 48 states now and has acute and non-acute membership. And really part of the reason that we became an LLC was value-based reimbursement was really starting, and value-based care was really starting to be talked about then in that time period. It was like 2015, 16. And what we noticed at Vanderbilt was we were responsible for the continuum of care cost when we were in a bundle with CMS for heart valves. And so that non-acute, we were doing good on the hospital side, but the non-acute side was actually not as good. And so we became an LLC simply so we could not to be able to say, oh, I've got a company, but to be able to affect the cost in working with the suppliers across that continuum of care, not just being focused on what the hospitals needed, but understanding what was needed from a supply cost elsewhere so that we could affect that entire thing. So that was sort of the genesis of becoming an LLC for that. We also, in 2007, when I started at Vanderbilt, the first thing that they did was said, oh, by the way, we're building this brand new critical care tower. We're adding 12 new ORs, building out all of our ICUs into 36 bed units, massive procedural areas, and we forgot to add space in the basement to do all of this for supply chain and sterile processing. And so one of my first tasks was to figure out how to support the hospital and that volume growth. And we ended up standing up an offsite case card operations center, which has one side of it is supply chain and one side of it is SPD, and build it to grow. And that gave us, we developed a toolkit as we were doing that to say, this is how we're doing it. We kept all of our documentation and all of our metrics and all of our financials. And then we started getting calls from people saying, hey, we're interested in doing this. Would you be interested? Can we do a tour? And would you be interested in helping us? And so we stood up the Supply Chain Solutions team, which I'm president of. And that is our consulting group that focuses really in that perioperative SPD space to really help with doctor preference cards, SPD, building offsite centers. And the center can be as complex as some folks are doing with a variety of different things in it and services, including pharmacy, but we have a different pharmacy site. Or it can be as simple as just working on supporting the OR and procedural areas. So that's how we got into the supply chain services. And then the last one,
I got one more. I think you got one more title.
the last one is CareFluent Connect, which I was president of up until July 1st of this past year. And CareFluent Connect was Vanderbilt's wholly owned DME company. And that came from a challenge from our CEO to the entire organization as we were looking at innovation, saying, think about what we can do that is unique, that can affect patient care, affect our providers. And I talked about that a little bit earlier. And as I was thinking about where supply chain fit in that equation, the DME solution was one that immediately came to mind because it was a quagmire. It was broken. There was nobody who was overseeing. It was not meeting patient needs. It was not meeting physician needs. It was not helping with getting patients out of the hospital in a timely fashion. People were sitting for days waiting for DME to come in. Their DME that they were getting delivered to their home, they'd had no education on. They got a pamphlet to read from whoever the provider was. And so we spent about a year talking to providers and figuring out the things that they liked that worked and the things that they didn't like and how they wanted to change it and how to develop it. And we stood up our own DME company and really started to be able to impact our discharges and getting folks out. I mean, like everybody else, we are full all the time in all of our sites, and we need to turn those beds. And really, the patient satisfaction went up, the physician satisfaction went up. And I'm very grateful to say that we went and did a number of interviews and selected a company to partner with who was also in this space. And that partnership, that joint venture, they bought into the company. And that joint venture was stood up as of July 1st of this past year. So the solution is still there, and it's got a company who's willing to continue to invest in the footprint and in the value proposition of it. And Vanderbilt can then spend its capital that's very much needed on other things that we need to spend money on. And we're not wholly trying to support the DME company from a growth perspective. So it made good business sense to sell it away, but it was like kind of giving my baby away as well too. So
Teresa, the savvy change agent, I just call you Teresa the fearless. That's a lot of titles and a lot of really tough things to do. I'm always counseling people away from commercialization because it's just so darn hard. But I remember in preparation for doing the Bellwether League's keynote on entrepreneurship, you and I had a chance to chat just privately, and you shared some of the challenges of commercialization and some of the secrets too of success. Anything you can share with our audience around how to approach these things?
Oh, there were a lot of learnings, especially with the DME company. And because there just wasn't anybody to go to find out what we didn't know about what was ahead of us, right? And how much capital investment has to occur on the front end and preparation on the front end before you can ever even think about dropping a bill to a patient. And the other major learning was organizational change and moving from this chaotic, I'll call whoever I want, I've got a relationship with so-and-so kind of thing, to it's a structured environment. Here's your order sets. Here's how you're doing it. Here's the company, sort of thing. That organizational change was very large. And having to shift responsibilities, understanding all of that, like who was owning this and at what time was it important for the physicians to start owning it as well, right? And some of that. So the biggest thing I would say is if you have the ability, do a lot of homework before you ever decide to invest penny one if you don't have, if there's nothing out there, nothing now, who knows, with AI and Chat GPT, they might make something up in the future, and you might do something on a maybe not the best information, but do as much homework as possible and really understand the front end impact and the time. How long is it going to take you to make that first nickel as well too, right? There's so many components that go into when you finally break even and then move into that positive balance, that there's nobody around sometimes in some of these, what people are thinking about doing, to really give them that information if it's truly innovative, I guess.
Lots of really good operators. Sales and service seems to be the biggest challenge in it of how to do that. But I applaud it, particularly the home care commercialization. I wrote about that for a long time, and I was always hoping that supply chain would get more interested in that home care aspect of it. And most haven't. I still think it's an area for opportunity, but have kind of decided that it's moving slow enough that I'm going to have to wait for people to kind of catch up. But maybe let's transition a little bit to leadership. So you were the AHRMM chairperson at one point. You've done a lot of leadership things, particularly around the clinical supply chain, and been an aggressive sharer, I would say, of the good things that you've been able to do at Vanderbilt and other places. But what's been that? What would you tell, up and coming leaders about the value of doing that for you and for Vanderbilt?
I have been so blessed by having so many amazing colleagues across this country that I have learned so much from. And so I'm not going to pretend that I know absolutely everything there is to know about supply chain even today, right? You surround yourself with people who have that innate expertise in certain areas, but being the chair of AHRMM and being able to send the message out about what was important to me and was also important to the board at that time around, clinically integrating the supply chain and really trying to get people to understand why that was important, and that supply chain is not transactional. It's a human relationship, and it's a calling. It's to do that, just like nursing is, right? You are serving. And you need to be collaborative with a variety of colleagues within your own healthcare organizations. But I really do think that the really wonderful time that I've been able to experience with the generation of supply chain leaders that I've been closest to, and then watching this next generation coming up, it is the willingness to share. Right? It's nobody's like, this is my deep, dark secret, and I'm not going to tell you because you might want to do that. Sometimes people will go and copy it, and that's just flattery, right? Whatever that is. But the willingness to share and try and help each other be better in our own organizations, and learn from each other's, failures as well too, because there's been failures and people have been open about those. And I think it's been good for all of us, and it's been good for the profession.
Well, you've been a great leader and inspired a lot of people, me included. Maybe let's talk about what's changed and what is changing. So in Vanderbilt, what's changed in supply chain over the last 3 years, and what do you see happening in the next 3 years for the supply chain specific to Vanderbilt?
I think what has changed is the level of engagement. So I talked about our physician engagement, but I never felt like it really was at the pinnacle of where it could be as far as our executive leadership engagement and the engagement of the chairs as well too, as physician leaders. And we have finally, over this past year, been able to hit that pinnacle. We've revamped what we called our executive MEOC committee, Medical Economics Outcome Committee, which is our version of value analysis. And we now have the deputy CEO of our health system, our chief medical officer of our health system, our chief financial officer of our health system, our president of our regional sites, and our largest hospital president sitting on this committee, along with my executive medical director and myself, Chief Supply Chain Officer, soon to be Yolanda Redmond, will be taking that position as I move into the full-time president roles, and really starting to get involved in the overall cost per case, impact of decision making that's going on in the organization, looking at KPIs that we've been monitoring for years around contract compliance and what's driving non-compliance, focusing on physician interaction and engagement at the executive level and the CMO level to really say, we need to do this differently. We need to change the paradigm. We need to spend our money where it's appropriate to spend the money. And we don't need to lay off 600 more people like we did last June. We have to really be conscious of what we are doing in this healthcare environment, and we need to be able to continue to grow. And we just bought another hospital. We closed on that for February 1st, and we flip it over fully to us on April 1st and for supply chain. And that has really led to a level of engagement, a rewriting of our executive charter, and major aha moments for our executive leadership where they're enjoying being educated on supply chain and all the little nuances of what we're doing and the different metrics and why all of that sort of ties together and is important for the organization. And so I can't think of a better position to leave Yolanda in to set her up for success as the Chief Supply Chain Officer than to have been able to get that up and established and now have that level of engagement and support and at the same time willingness to question and challenge us, right? And make us go back to the drawing board on some things. So I think that's been the biggest change that has happened for us here in the last year.
Yeah, that's amazing because I've been watching, kind of the clinical alignment side take a back seat to just servicing and staying up, and certainly the financial pressures. So, kudos to you, and maybe balance that, like how, like a lot of health systems are under significant financial pressure, and that's always, right? Supply chain's been there, but it seems like it's really ramped up in the last couple of years. And do you see, how are you thinking about that? Are you investing more in technology? Are you thinking about different approaches? What's the mindset at Vanderbilt today around cost pressures and supply chain?
It's a couple fold. One is, as an academic medical center, we're always going to want to be participating in research initiatives, having the latest and greatest technology that is, clinically superior, driven by data, decision-making driven by data available. And that's part of the reason of standing up this executive group differently than what we had before, because anything now, we are constantly asking to be introduced new products or technology through our standard committee. We've always taken a look at contribution margin and the impact of that by changing the cost per case with introducing almost always, it's more expensive technology or products. And our charter before allowed president of the site, who is often potentially influenced by the physicians that are at that site, and coming to his or her office to have conversations around their needs, and the chair of the department to decide, even if it had a negative margin, they would sign off on it if it passed the clinical sniff test to come into Vanderbilt. Now anything with a negative margin goes to this executive committee, and there is serious contemplation relative to, is this the path that Vanderbilt wants to go down? What's the mission? How does it support us? And then it's the executives driving the decision. So, and I think that's important because then the chairs and the physicians, the administrators of the departments, and the presidents of the sites, they have the support that a decision was made at the highest level that, yes, we want to be in this space and we believe this technology needs to be here. We're doing the same for our robotics program. Instead of all these sites getting their own robotics and making their own requests, we stood up a committee that is has key physician leaders, chairs of a couple departments in there, has some hospital administration, presidents of sites, finance people, and we're looking at making the best decisions on introducing robotics and where should they be. And should it be in one of our regional hospitals versus on our main campus? Should we have it in an ambulatory surgery center? So we've developed this whole template about really assessing the need and then the pro forma and then the impact margin. And then that all gets shared with that committee. And they are driving the decisions now instead of somebody saying at a site, well, on my capital plan, I have a new robot budgeted for 2026 and I'm going to buy it, right? No, we're taking that to the next level this year as well, too. And actually just had our first formal meeting with physicians presenting and administrators presenting about wanting to get robots in. So I think that's exciting, but it's necessary as well, too, because those cost pressures are real. Reimbursement isn't getting any better. And we have to look at technology in supply chain on how do we help affect that curve. And I really am excited. And when I was asked, who do I think is the next ideal candidate for the chief supply chain officer for Vanderbilt, I said, I really think it's somebody who's got to really love technology and want to get in there and get dirty with it and gets excited about it, because that isn't me at all, and have a strong finance background. I think now we've got a strong enough system, a clinically integrated system at Vanderbilt. You don't need a nurse leading supply chain there. You need somebody who's going to take it to the next level in these other categories and really focus there. And I think some of the technology that's going to be coming out will impact supply costs and will impact organizational costs because of the ability to do work where work is needed by humans and have automated work taking up some of that and really trying to reduce the overall expense that way. And so I think the future is bright, and getting clinical staff out of having to do supply chain work. I maximizing their time in the room, what they're doing, what they're focused on. If they're not worried about, did this scan, this didn't scan, what location did this come from, et cetera, and they can get their case closed, that patient out of the room and turn that room around, that's revenue for the organization, right? Productivity for the organization. So that's where I think supply chain really needs to focus coming up, and using technology to help impact some of that, not just expense, but also revenue.
I'm with you. I talk about it in terms of doubling the investment in technology, and you're right. This connection to budgeting that you referenced, just in the one example across the board, I'm seeing some real leadership happening there where it's less just broad and much more targeted. And I think it's healthy for the organizations. Well, this has been tremendous. Do you have any parting thoughts before I close this out?
I just want to say to you, I'm very blessed to have had you in my life and relationship that we've had as friends and colleagues. I've learned a lot from you as well, too. My parting thoughts are, I've been doing this, as I said, for 25 years. I was in nursing. I'm not even going to tell you how much longer before that. I'm excited about the future of healthcare. And I think that supply chain leaders have this enormous opportunity in front of them to just be such an integral part of the solutions for their organizations. And I'm hoping the next generation that is coming up make sure they get the right people in the right seat on the bus for the team, and have those different levers of expertise that they can draw on and pull on to help support them. And I just think it's wide open. It's a blank canopy right now that can be painted in so many different ways. And it's kind of sad that I'm at the end of my career as all of this is happening, and it's happening so fast. But at the same time, I feel like we've done a lot, that my generation here has done a lot to get the supply chain where it's at. And now I'm ready for that next group to take it and make it even better.
And take it they will. Teresa, you're generous and a great friend to me and to the healthcare supply chain industry and the clinical side of the house, too. We won't forget that. And with that, thanks to our audience for being here. Thanks to the great Teresa Dail for sharing her thoughts. I'm Eric O'Daffer. This has been Smarter Sourcing Healthcare, and have a great day, everybody. Bye.